thank you for putting together such a fine and interesting conference about certainly a very important subject. And the subject of the conference, of course, is the long road to equity for women in medicine. And I hope in my presentation today to maybe uncover one of the causes of a very complex issue of why my title can't be the achievement of gender equity, but we're still searching to achieve gender equity for women in medicine. My objectives include defining what we mean when we talk about implicit bias in general. And of course, this talk is specifically about gender bias. Describe the development and impact of gender bias, both professionally for women in medicine and on health. Provide examples of the above objective, and briefly at the end, describe some strategies that may be used to minimize the effect of implicit bias. Before I give the definitions of equity, I'd like to just start with a conversation about why we're talking about this. And it's really because there still continues to be disparity, both professionally and in healthcare, when it comes to women. One of my favorite definitions of health disparity was put forth by Margaret Whitehead back in the 1980s, early 1990s. Up until recently, she was director at the World Health Organization of social determinants of health. She defined health disparity as the lack of health equity concerning differences in health that are not only unnecessary and avoidable, but are considered unfair and unjust. And these types of health differences are not just due to differences because of age or underlying other underlying issues that we can't control for, but health disparity really refers to health differences in vulnerable or marginalized populations, which there are many under this umbrella of health disparity, including disparity based on race, sexual orientation, age, gender, and that's what we're talking about today. So why haven't we achieved health equity yet? In medical training, it's really not a pipeline issue, which I'll discuss. It's not a lack of interest. Male and female faculty at academic medical institutions express comparable commitment to their career advancement. And it's not really a lack of talent. We see many examples of women across business, in medicine, in science, that are very talented. So what was concluded from the National Academies of Science Task Force back in 2007 in a piece called Beyond Bias and Barriers, that it's not a lack of talent, but unintentional biases and outmoded institutional structures that are hindering the access and advancement of women. So when we talk about health equity, professionally, we want all people, all women, to have access to the ability to rise in their professional career in an equal way as to anyone else within that institution. When we talk about why we have not achieved health equity in terms of healthcare for women, this report was really a seminal report that was reported by the Institute of Medicine, now called the National Academies of Science. It was called Unequal Treatment: What Healthcare Providers Need to Know About Racial and Ethnic Disparities in Healthcare. This came out in 2002, 2003. And although the report was about racial and ethnic disparities in terms of, and not specifically about women, what we I feel from this report, there are conclusions that can be generalized to any population that is experiencing healthcare, including women. And what they have reported is that although myriad sources contribute to these disparities, some evidence suggests that bias, prejudice, and stereotyping on the part of healthcare providers may contribute to differences in care. And this seems like a simple statement, but at the time, this was unheard of. It was very ground shaking in the fact that it suggested that actually physicians themselves, other people in healthcare, based on their individual biases and stereotyping, may contribute to health disparity. And they went on further to say that because of the origins of implicit bias, or bias in general, arise from virtually universal social categorization processes, they may also exist, often unconsciously, among people who strongly endorse egalitarian principles and truly believe that they are not prejudiced. And in fact, studies since then has supported that. In the fact that often when doctors are questioned, they do agree with a statement that bias may affect and increase health disparity. But when asked about, does that affect your own individual practice, the answer changes, that no, it doesn't affect my individual practice. So what's learned from this is that even people, and I would venture to say that most of us in healthcare come in with the belief that we have egalitarian principles, and yet we are somewhat blinded to the fact that we are all subject to implicit biases, which I'll explain in this talk. So what are we really talking about when it comes to implicit bias and explicit bias? What are the definitions? So bias we could just think of as an unfair attitude that may positively or negatively affect how we view the world and how we treat people. When it comes to explicit bias, we know that overall, sometimes lately maybe it doesn't feel like that, excuse me, but overall, we see that explicit bias has declined in the last several decades. And what explicit bias really refers to is that it reflects our intentional responses. These responses are subject to introspection and tend to reflect beliefs that we endorse. We're aware of them and we can control them. In contrast, unconscious bias really functions at a level below our awareness, and it can affect our decisions in ways that we are not aware of and may conflict with our explicit beliefs. So we see that these implicit biases or attitudes are automatic, and quick. Because we're unaware of them, we may not endorse them, and we may not be fully aware that they are affecting our decision-making, including in medical decision-making. So what are some examples? So for instance, in academic medicine, some people may hold explicitly that women are less likely to be committed to their careers, especially women who are parents may be less likely to be committed to their careers. And subconsciously, or something we're not aware of, because of this more explicit belief, we may view women as being less competent in terms of career success, whether it's as a clinician or someone who wants to rise in an academic medical center. So our previous speaker spoke about this, really so eloquently. And I'd like to just continue the conversation about intersectionality, because I do believe that this is yet another reason why we haven't achieved equity, and it's important to highlight. So intersectionality was developed, that concept, that term, by a Black feminist scholar in the 1980s, 1990s named Kimberly Crenshaw. She defined intersectionality as the interconnected nature of social categorization, such as race and gender, that create overlapping and interdependent systems of discrimination and disadvantage. So yes, we could talk about implicit gender bias, which is the focus of today's talk, with the understanding that sometimes these marginalized characteristics or populations that people identify with, we all have more than one identity. And sometimes these vulnerabilities interact with each other and create even a worse situation, impacting health disparity or professional development. And in this case, I'm just going to use Dr. Susan Moore as an example, a Black woman who, I'll tell you, give her example. She really rose to national prominence after she posted a Facebook video that went viral, in which she said she's a family physician that was practicing in Indiana. She trained at University of Michigan. And in the fall to winter of last year, she was admitted to an Indiana hospital for COVID. And she said that racial bias in this Facebook video, which I encourage you to look up, led to her healthcare providers ignoring her pain and failing to treat her appropriately. Moore said that the white physician who treated her there did not take her neck pain seriously when she described pain in her neck and difficulty breathing. She said he made her feel like a drug addict and would not prescribe adequate pain medication. Finally, a CAT scan was ordered, and it showed significant lymphadenopathy in the neck that explained both her shortness of breath and her pain. At that point, her pain medication was adjusted. And what we'll see is that women in general are not adequately treated for pain, including this intersectionality of Black women. She, despite not feeling well, she was discharged from the hospital. Within 12 hours, she was admitted to another hospital and unfortunately died 3 weeks later from COVID. There was a very powerful editorial called Say Her Name, Dr. Susan Moore. Thea Malbank is actually someone that did her preventive medicine residency here at Stony Brook, and she's currently the first chief equity officer at the AMA, and other leaders in the field, especially about discrimination and racism. Camera Phyllis Jones, Yuki Blastock, and Joya Perry wrote this article in December of 1920. So what this draws attention to is how the intersectionality builds between gender and race, and how discrimination results in worse health outcomes, even for, women who, that can advocate for themselves, like Dr. Susan Moore was able to. But it's really based on having differentials in power, in the control over one's environment, in the types of jobs that are available to them, and lack of trust in the medical system. And we'll discuss these to some degree shortly. But less trust in the medical system is not only historically noted because of, experiments like the Tuskegee experiment, which took place from the 1930s to the 1970s, which still echoes in today's healthcare about lack of trust in our healthcare system. For those who may not be familiar, it was a study of Black men who had syphilis that continued for almost 30 years, even after a cure for this was available, which was penicillin. There's also other reasons why marginalized communities may not trust the healthcare system to date, whether it's access or feeling discriminated against or not having specialties within their neighborhood. So there's lots of reasons why there's impact of intersectionality in terms of the continuation of health disparity for women. And as we learned, the social determinants of health are defined by where people are born, live, work, and play, worship, and age. And these social determinants affect a wide range of health and functioning and quality of life outcomes and risks. And just to continue with how gender and race may be intertwined in terms of risk for increasing health disparity, we see the social determinants of health, such as where someone lives, their socioeconomic status, their access to quality education and ability to be educated beyond public high school. Nutrition, does the person have access in their neighborhood to high quality, affordable, fresh foods, or is the neighborhood a food desert? And the actual physical and geographic location of a neighborhood. And what we know is that in this case, Black individuals are more likely to live in highly segregated areas that do have food deserts and that are more likely to also have the lack of green space for exercise, increase environmental injustice such as pollution and smog. These are the social determinants which affect the moderators. In this example, I'm talking about racism and sexism. And we know that based on these factors, there is a lack of access to quality care in certain neighborhoods. As we discussed, there's a lack of trust, and that certain diseases may be undertreated or underdiagnosed, such as pain, such as preventive screenings, and maternal care, both maternal morbidity and infant mortality. How did this impact COVID? What we saw, as what was described in the previous lecture, that there was an overrepresentation of essential workers in the communities of color. Also within the Black community, there's a higher existence of comorbid conditions such as diabetes and cardiovascular disease, which also increases your risk of morbidity and mortality when it comes to COVID. Especially early in the pandemic, there were not adequate testing centers within these very segregated neighborhoods. And within these neighborhoods, not only was there a higher density of people, which makes your likelihood of being exposed to COVID higher, also people lived in more crowded living situations. So it's how these social determinants combine with what we consider factors that increase the likelihood of health disparity has created really very high morbidity and mortality for Black women from COVID disease. So now I'm going to switch gears a little bit and talk about implicit bias and its development, how it may be seen as habits of the mind or unintentional responses that influence decision-making. So what is the process of bias formation? What we see is that in order to get through our day, we need to it's estimated that the human brain processes 11 million bits of information per second, yet the unconscious mind cannot process that amount of information. So it appears that vast majority of processing is accomplished outside the conscious awareness, suggesting that practice and habit are important to allow the brain to automatically react without conscious interference. And this is why we could start thinking of implicit bias as a habit of the mind. So in order to efficiently get through our days without having to think about every single decision we make, you know, when you drive home from work, you're pretty confident about the route. You're not really needing to put too much mental energy into that, and the multitude of other decisions that occur each day. So we categorize the outside world to an internal mental picture. And this stems from our natural evolutionary tendency to form associations to help organize our social world. So if we think back, you know, centuries ago, hunter-gatherers needed to make rapid decisions of, is this a dangerous situation or can I continue gathering the food for my family? And these categorizations continued as society developed. And what it is, it's how these categories are developed is through our experiences, expectations, and culture, our family, our religion, how we grow up, where we grow up, influence how we categorize our social environment. And what we know is that these assumptions influence our interpretations and responses to others. And this leads to stereotypes, a natural process. And the Institute of Medicine years back defined stereotypes as the process by which people use social categorization, such as race or gender, to acquire, process, and recall information about others. So for instance, if we're on the highway and we see a speeding car coming behind us, we'll react differently if we categorize that car as a police car that maybe wants to pull us over, or a random sports car that's speeding. We have very different responses to being asked to undress. If it's a stranger, or if we're in the doctor's office and they want us to put on a gown so we could be examined. So these fixed impressions of a social group often lead to overgeneralizations based on the stereotyping. And the overgeneralization, all of a sudden we're thinking of an individual as part of a group and assuming that all those group categories apply to the individual. So what we see, you know, obviously that's not the case. So this translation process is not infallible, and it may conflict with our conscious beliefs and our choices about how we're going to perceive and treat others. So let's just take a look, if you want, will do this exercise with me. My question is, do the size and shape of these tables look identical? So give you a second to formulate your answer. I made a template that's red, and I am slowly moving it over to the other table. And I think what you see here is that, in fact, this template fits just as well on this table as it did from where it started. And if, so the interpretation of this visual scene of the two tables is influenced by our past experience with objects that seem to recede into the background. We did this quickly and unintentionally, and if you're like me, I still have trouble seeing that these two tables are identical. So if you will take a leap of faith with me and consider social perceptions may also be considered analogous to this object perception, that sometimes the reality does not match our perceptions of the environment. And this also leads to habits of the mind. This is discussed in a wonderful book by social scientists, Dr. Banerjee and Dr. Greenwald. And they wrote a book called Blind Spots, Hidden Biases of Good People. And they were also influential in developing a way to measure hidden biases called the implicit association test, which I'll talk about in a few slides from now. Their definition of blind spots, of course, we know blind spots is where the retina, the optic nerve inserts into the retina and is devoid of rods and cones, so we have a blind spot. The social scientists have borrowed this term to refer to the hidden biases and judgments that you are not aware of, yet are capable of guiding behavior, including decision-making in healthcare. So who stereotypes? I continue to use this riddle in my presentations because although I think many of you will get the answer pretty quickly, when I talk to medical students and others, there's still some people that don't get the answer. It's not intuitive. So I'm going to read the riddle. A father and son get in a car crash and are rushed to the hospital. The father dies. The boy is taken to the operating room, and the surgeon says, I can't operate on the boy because he is my son. The question of the riddle is, so who then is the surgeon? And before I give you the answer, I'm sure we all have stereotypes that we could think of. Men don't ask for directions. Why hire an older worker if they're so close to retirement? CEO we envision is generally white and male, or many of us may, and obese individuals may be considered lazy and unintelligent. Even in the medical field, when studies have looked at physician attitudes about obesity, these are the stereotypes that are held. So stereotyping is very common. It doesn't mean we're sexist or racist per se. It just means we have been raised in an environment where there are certain social cultural norms that we have ingrained in our thinking processes. So who is the surgeon? It's been really interesting in the last couple of years. Sometimes the first answer I get is this must be a same-sex marriage, so the surgeon is the other father. When this riddle was developed decades ago, the answer that was being looked for is that the surgeon is the mother. So intuitively, it's interesting to me that in more recent years, some of the responses have said, well, it must be the other father. So we're still in a situation where being a female surgeon is still not intuitive. It's still difficult for some of us to process. And these are stereotypes based on our need for categorization to organize our world. So we look, other examples, look at these word images of how girls versus boys are described. We see that girls are gendered in terms of playing with dolls, the boys not so much. Even on covers of Sports Illustrated of two great tennis players, Roger Federer is here seen swinging a beautiful forehand, I guess, and that he's the master, whereas Anna Kournikova is seen certainly not as a tennis player in this image. And one last exercise that I'd like to go through just to really understand how stereotypes develop, which underlie our development of implicit attitudes and biases. I'm just going to say one word. And after that word, I just want you to get that mental picture in your head of the person that is being referred to. So a CEO, a Hollywood director, an inventor, a head coach, a top surgeon. Who did you picture? What sex were they? What gender? How old were they? What was their race? Why are we still asking the medical society to stop calling me a female surgeon? I wonder who you thought of. If, often there's a stereotype just based on words that create an image in our head. And that stereotype is to some degree an exclusion of others in terms of thinking about who can be successful, who is the most successful. So when it comes to success in academic medical institutions and other places, we think about gendered stereotypes. There's two types of stereotypes I'm going to talk about now. One are agentic characteristics and the other are communal. Agentic characteristics are defined just in the medical dictionary as denoting self-directed actions aimed at personal development or personally chosen goals. And I don't think I have to spell out which are considered male and which are considered female. Agentic characteristics are often more valued in men and often almost unacceptable in women. Agentic characteristics include things like confidence, independence in decision-making, competency, ambition, and assertiveness or aggressiveness. Whereas there are communal characteristics, which are more commonly thought of in terms of describing women, include caring and thoughtfulness, being supportive to those around you and compassionate. And this is why, based on these gendered stereotypes, where two leaders putting forth the same plan may be stereotyped differently, where as the woman may be considered calculated, the man may be seen as strategic. And this takes its toll in terms of advancement and success within an institution or business. When it comes to medical specialties, this happens also. What we see is that some specialties, especially the higher paid ones, are considered agentic. Things like orthopedics, neurosurgery, radiology, urology. These specialties often are considered to have higher status and are more likely to have a larger percentage as males of male doctors in these specialties. The proportion of women increases and the status decreases in terms of where women are found in terms of subspecialties and specialties in medicine. Women are more commonly the majority of pediatricians, family doctors, OBGYNs. And as was discussed, the status of there's a feminization of certain specialties, and that means less salary, less prestige, and status. Before we leave the concept of bias, there are, which I only discussed explicit and explicit bias at this point, there are many cognitive biases concepts other than that. And these include expectancy bias, prescriptive gender norms, and stereotype threats. There are hundreds of these, but I'm just going to use these three as an example of gender bias. So expectancy bias is defined as expecting certain behaviors in individuals based on stereotypes about the social category in which they belong. So studies have shown, for instance, that there's actually a motherhood penalty. In a Goldberg design, which implies research that is based on the raters looking at the same resume, and the only difference is the sex of the individual that's being rated. In this case, it was the sex of the individual, either male or female, and whether or not they were a parent or not. And there was found to be a motherhood penalty in that the moms who were rated as being less competent and less committed in terms of, would you hire this person? There's also something called prescriptive gender norms, which assumptions about how men and women should and should not act. whereas women leaders may be considered bossy, male leaders may be considered competent and very good at their job. And then unfortunately, this is something called stereotype threat, whereas members of negatively stereotyped groups may underperform when reminded of their group membership. And there's been numerous studies, and these have been replicated, first beginning like in the 1980s and 90s, about performance on a math test. So when when boys and girls were in a room for this experiment, and they were asked to take a math test, there was a difference in the performance based on how the boys and girls were primed. If they were told that this test seems to produce, differences, gender differences, where boys perform better than girls, in fact, what was seen is that the girls didn't perform as well as the boys, versus the other situation where if boys and girls, before they took the test, were told, you know what, boys and girls seem to do just as well as each other on this test, there was actually really no disparity in terms of performance in the math tests. So these are just examples of other cognitive biases that may affect individuals. So my general takeaways are that implicit processes usually serve us really well. We need to categorize, stereotype to get through our day. It's when these stereotypes are overgeneralized that they become subject to error and inform our decisions and reactions to others in a way that is not based on their actual individual characteristics. That are implicit social biases link people, create disadvantages for some groups and advantages for others. And as I said, prejudice, habits can conflict with our conscious beliefs. So how may this be measured? One way to do it is the implicit association test. And if you haven't heard of this test or if you've heard of this but haven't taken a test, I really encourage you to go to the website implicit.harvard.edu and try taking a test. And my interpretation of the implicit association test is that it really measures dominant stereotypes in our society stemming from our natural tendency to organize the world. So I see the IAT as an educational tool to develop awareness of implicit preferences and stereotypes within our culture, our society. So for example, I wouldn't use an IAT to eliminate jurors that may score higher in terms of implicit association for whites versus Black, but I would use it as a tool to help people become aware that we all harbor these implicit biases, and that awareness hopefully will help people to overcome these biases. So the implicit association test is scored by using a D-score. The scores range from -2 to +2. And the assumption of the test is that sorting concepts is easier when compatible concepts share the same response key. This is a computer-based test. And that this faster categorization of congruent terms over incongruent terms will create a time latency, and the difference in this response time is scored as the D-score. And what's really, I think, has become very clear through the use of the IAT over the past couple of decades is the reinforcement that these are ordinary, that we all have implicit associations, that they're very pervasive, and that they can be consequential in terms of predicting our behavior. So I'd just like to discuss something called the Stroop effect, which was actually developed by a psychologist in the 1930s, Dr. Stroop. And this really is the underpinning of the implicit association test. He developed the color naming test, and he used two trials, a compatible trial, congruent concepts, and an incompatible trial or an interference concept. So this test refers to the interference and reaction time of a task. So in the first compatible trial, the goal is to say the name of the ink. You want to say the ink. So it's pretty easy. You could say it to yourself: red, black, brown, green, yellow, and blue. The incompatible trial has the same directions. You're still saying the color of the ink, but it's a little tougher. So this would be blue, green, red, yellow, black, and brown. I've seen this slide several times, and I still hesitate in terms of the task, because our initial premise would be to read how the word is written, but that's not the task. And the same underlying concept was developed for the implicit association test. So for instance, there's an implicit association of gender and science. The congruent trials will pair male names with concepts related to science. Conversely, the congruent trial will pair female names with words related to liberal arts. The incongruent trial reverses that, and this is how the D score is developed. Does it take longer to correctly associate an incongruent pair than it does a congruent pair? And actually the answer is yes. This is data from the implicit association test website that looked at responses in terms of gender science IAT results from 2003 to 2015. And this includes over 600 responses. And what was found is that close to 70% of individuals who took this test did show slight, moderate, or strong automatic association with male with science and female with liberal arts, the very strong cultural stereotype that we see in our society. So I think what the implicit association test also has helped us understand is that implicit preferences can lead to discrimination in hiring and promotion. It impacts very much so patient-provider communication and some medical decision making, some medical decisions, and that the very nature of how we practice in healthcare as physicians or other healthcare professionals cause us to rely more heavily on implicit attitudes. I think many of us can relate to situations where we've had to practice where there's limited time. Our encounters are briefer than what we need them to be. There's uncertainty about the diagnosis, or a very complex patient comes to us and we have limited time to make that diagnosis. It's these very characteristics of how we may need to sometimes practice in medicine that actually leads us to rely more heavily on our implicit associations. So how does that play out? What has research shown us? At first, actually, this wasn't research in terms of orchestra auditions. There was concern in the 1970s that fewer than 10, that most of the orchestra members came from a very select group of master teachers. And so because of this, because of the desire of the selection process, the selection members, to choose a more diverse group of students from different teachers, they decided to blind the auditions and put up a screen. And yes, it was true that there was a higher percentage of orchestra members now being selected from many other and many other teachers. But what was surprising at the time and unexpected is that in 1970, fewer than 10% of orchestra members were women. Just based on the blinding by putting the screen up, what was found over a 20-year period, that the proportion of women that were hired in orchestras went up by 40% to 40%. Other experiments have used the Goldberg design, which I described. And again, just it refers to a design that uses the same piece of work, for example, a resume, and the only difference is between whether it's a male or female. That's the one difference in the Goldberg design. So there was a relatively recent research paper in 2012 that actually used the Goldberg design to assess, is there an impact on hiring based on gender? And the resumes of individuals, only difference was whether they were male or female, was given to science instructors, and they thought they were actually looking at these resumes to hire a lab technician, often an important step before someone goes on for their doctorate. This is a pre-doctoral type of position. And what was found was that just based on whether the resume was that of a male or a female, that overall, all of the people rating these individuals for the potential job felt that the males were more competent, more hireable, and would do better with mentoring than the females. Also, when salary was looked at, there was a differential in what was in the offer for the starting salary of close to $4,000. This study did not use the IAT, it used a different tool to measure gender bias. The tool they used was the modern sexism scale. And what was found was that the scientists, or the people who were rating the person to be hired, who had higher degrees of gender bias on this modern sexism scale, were also more likely to rate the male as would benefit from mentoring more, was more hireable, offered a higher salary, and was felt to be more confident. So what evidence do we have now, getting back to academic medical centers? As I said earlier, it's not a pipeline problem. For the last close to 20 years, medical school applicants have been on par with, female medical school applicants have been on par with male medical school applicants in terms of applications to medical school. We see that still their medical school graduates are slightly less than 50%, but it's pretty close to 50%. Yet we see a drop-off in terms of underrepresentation of women in terms of achieving higher status positions. And while we see each year, if we compare these percentages to like 10 years ago, we see that there has been improvement, but still the highest percentage of women at academic medical centers are instructors. And in fact, when we look at deans, we've added in the last 10 years, 1 dean per year in terms of being a dean at an academic medical center. So we still, even though there's improvement, we certainly still have a long way to go in terms of achieving equity in job status at academic medical institutions. When we break this down, if we get back to thinking about intersectionality, what we see is the percentage of underrepresented minorities in medicine has really not changed at all in the last 10 years. So we see how that combination of factors of having more than one vulnerable characteristic still keeps women from achieving success comparable to what their percentage is in the population, or comparable to even white women and certainly to white men. So what evidence, why might this be happening in academic medical centers? What we know is that, for instance, starting even in the training arena in medical school performance evaluations, which are so important in terms of applying and getting into the residency of your choice, tends to have gendered descriptors of the male versus female applicants. Words difference, women may be described more often with personal attributes like they are lovely or compassionate, not that there's anything wrong with compassion, whereas male evaluations may be more likely to refer to their competency, that they're standout in terms of leaders or other competency words. And this has also been shown to be true even in specialty residency training, such as emergency medicine. The characteristics that are valued are agentic, confidence, decisiveness, assertiveness, and this places the female residents, the female medical students at risk of disparity if agentic characteristics are more highly valued and not seen as possible in women, or that when women do possess agentic characteristics, may be even given a penalty because of that. So language and wording is so important in terms of early academic success. Even in terms of surgical residency, studies have looked at amount of operating room time. There's a difference between how much autonomy female surgical residents get versus male residents. Moving on to faculty in academic medical centers, we know that grand round speakers are more likely to be male than female. And what I find very interesting, when this has been looked at a little bit more closely, they've looked at introductions of how male versus female speakers are introduced. And they based it on who is doing the introduction. So when in a scientific or medical center. So when a female is introducing the grand round speaker, what the percentage of time that the female actually introduces any speaker by their formal title of doctor, let's say, that's matched greater than 90% of the time. Men introducers are less likely to introduce even men by their formal title, about 75% of the time. But in terms of introducing women, that falls off to about 50% of the time. So more casual introductions are seen by men when introducing female speakers. And this may seem like a small, not a big deal, but the message that it gives to medical students, to residents, to other physicians is one of less respect, less status for the female who is being introduced at the grand rounds. We know that authorship, although it's improved somewhat in terms of first authorship in impact journals, there's still the majority of first authors are male. And unfortunately, this gender disparity grew during the pandemic. So the pandemic, since the pandemic started, in just the United States, submissions increased by 24% from men, but only 8% for women. So this disparity grew, part for many reasons. Being that we see that as there are less women in higher positions at academic medical institutions, it also means that there's less mentoring for our female medical students and residents. And mentoring is considered a very important aspect in terms of career development. And what we saw in that study I talked about, there's differentials in salaries, even when all factors are controlled for, whether someone works part-time or how many patients are seen, when all factors are controlled for, women in most specialties still make less income than their counterparts do. So moving away from academic medical centers, how does implicit gender bias affect healthcare? What we've learned is that the rate of implicit bias is similar in physicians and the general population. Yet few studies have directly examined implicit attitudes with an IAT. We have studies that have looked at more recently, just measuring that implicit gender bias actually does exist within the healthcare profession. And I'm going to talk about the one study I'm aware of about implicit gender bias and the use of cardiovascular tests among cardiologists. And before I do that, let's just remember our gender stereotypes assumes differences where there is sameness. So women are often perceived in the medical field, in healthcare by providers as being more emotional, more likely to seek medical attention, which they may see physicians more frequently, but that they tend to exaggerate their symptoms, that there may be psychosocial reasons for their seeing a physician. And examples include the undertreatment of pain, the lack of recognition of heart disease, the longer time it takes to have a joint replacement recommended. And what we've seen is that Black women have a higher rate of mortality from COVID-19 than all other groups except Black men, again, going back to that gender and race disparity. So one study looked at, used actually the implicit association test for risk and strength, and used this to determine did cardiologists, 503 of them, decide differently on what recommended treatment they would give for their patient based on their implicit association bias. And what was found is that most of the cardiologists had slight, moderate, or strong associations of males with being risk takers and males with strength. And what was interesting, it was found that yes, indeed, implicit bias did affect the recommendations of these cardiologists. In fact, as the physicians had higher implicit bias, they were less likely to recommend the utilization of angiography for women as compared to men. So the association was there in terms of the IAT for strength, but when other factors was controlled for, did not reach significance. It remains significant in terms of physicians having implicit bias in terms of associating men with increased risk taking. So it did affect actually the implicit bias, which is also often inferred in studies, in fact, did affect their treatment decisions. So to wrap this all up, what kind of strategies can we use? I think it's become clear that we really need to approach improving and reducing the impact of implicit bias, both professionally and in healthcare, by a multifactorial vision. And that includes, organizational or systemic, individual, and the combination of both. So really, it's going to be hard to affect meaningful change unless there's leadership that is committed to cultural change. And part of that commitment is diversifying our experiences within the institution by hiring people of different backgrounds. Also, just concretely, the more evidence-based medicine we could use, the less likely we are to refer and need or use our implicit associations. In terms of individual self-reflection on personal bias, education and awareness, questioning stereotypes. I call these doorknob, tools that we could think about before we go into and examine a patient. Think of counter stereotypes of individuals. There's perspective taking, or considering the experiences from the point of view of the person being stereotyped. Individuation will help decrease the impact of our implicit biases. Individuation refers to evaluating people based on their personal characteristics rather than those affiliated with the group. And finally, putting this all together with cultural humility, understanding that we are lifetime learners in terms of others, that we need to diversify in terms of our institutions so we could achieve the mentorship for all people within our institution, and that we continue to have anti-implicit bias education, both at a professional level and for our students, in order to really achieve equity for women.